Welcome to the Australian Dental Council Explainer podcast.
Glad to be here for this one.
So imagine this. A female patient presents to your clinic.
Okay.
4 days ago, she had a difficult surgical extraction of her lower left third molar involving bone removal.
Right, a classic scenario.
Bleeding stopped normally, but yesterday a constant, dull, boring pain began. It's radiating, it's totally unrelieved by paracetamol, and it's keeping her awake.
That sounds miserable.
It really is. She has halitosis trismus with only 22 millimeters of interincisal clearance and moderate extraoral swelling.
Okay, so a very specific presentation.
Exactly. And when you look intrally, the socket contains absolutely no tissue, just food debris.
Yeah.
And the distal bone is completely exposed. What is your initial differential diagnosis?
I mean, that is the ultimate clinical test, right?
Yeah.
You are presented with a patient in absolute distress,
Yeah.
You've got a highly specific post-operative timeline and a very localized set of symptoms that point toward just a catastrophic failure of the normal healing cascade.
Right. And before we completely deconstruct the pathophysiology here, I really want to hear from those of you listening right now.
Yes.
I'm pinning a comment on this deep dive right now, asking, what do you think when a patient comes in with a dry socket or, a similar unhealing extraction site?
It's a great question.
What is your immediate go-to thought process when you see bare bone? Drop your answers in the comments while we get into the clinical weeds.
Perfect. But to establish our framework before we proceed, I need to state clearly that this discussion is purely educational.
Good point. Yeah.
Our goal is to assist clinicians and candidates preparing for the ADC exam by, mapping out high-level clinical reasoning.
Right. So we are not sponsored here.
Exactly. This is absolutely not a commercial endorsement of any pharmacological products, specific brands of surgical dressings, or the texts we reference.
So our mission today is to thoroughly unpack this specific clinical presentation of alveolar osteitis.
Which is widely known as a dry socket, of course.
Right. We're going to examine the investigation, the biological mechanisms, and the management protocols. And we are relying heavily on Odell's clinical problem solving in dentistry.
Specifically, utilizing case 15 from that book.
Yeah, which perfectly mirrors the scenario I just laid out. But we aren't stopping there, are we?
No, we really want to extrapolate this data to analyze other complex, failed healing socket scenarios.
Let's start with the baseline biology. I mean, in a standard, uncomplicated extraction, we rely on primary hemostasis, so platelet aggregation, followed by secondary hemostasis.
Right, where the coagulation cascade produces that really robust fibrin mesh.
Exactly. This blood clot is the biological scaffold that's absolutely essential for fibroblasts and osteoblasts to migrate into the void.
It's the foundation of everything.
So in case 15, we are looking at alveolar osteitis. How does a seemingly stable fibrin scaffold just completely disintegrate by day 3 or 4?
Well, the disintegration isn't a passive process at all. It is an aggressive, biologically mediated destruction of the clot.
Hey, really? Aggressive how?
The underlying mechanism is excessive fibrinolysis. In a normal socket, the fibrin mesh stabilizes the clot, which allows granulation tissue to proliferate from the base and the walls of the socket.
Okay, that makes sense.
But in alveolar osteitis, tissue plasminogen activators, or TPAs, convert plasminogen into plasmin.
And plasmin is the problem here.
Exactly. Plasmin is a proteolytic enzyme that just ruthlessly degrades the fibrin polymer network.
Okay, so it's actively tearing down the scaffolding.
Yes.
Can we use an analogy here? Is it kind of like a scab being washed away in a rainstorm before the skin underneath actually has a chance to heal?
That is a perfect analogy, yeah. The rainstorm in this case is the fibrinolytic activity.
But we know surgical trauma releases tissue factors that trigger coagulation. So you are saying that the same surgical trauma is releasing the very enzymes that destroy the clot.
Basically, yes. It's a delicate balance.
But if trauma releases TPA, why doesn't every single surgical extraction result in a dry socket? There has to be, I don't know, a threshold effect or a secondary catalyst.
You're spot on. There is a threshold. And that secondary catalyst is almost always microbial.
Ah, bacteria.
Right. The local tissue trauma from, say, elevating a flap and removing bone releases a baseline level of kinins and tissue plasminogen activators.
Okay, so the local trauma primes the site.
Exactly. But when you introduce specific oral bacteria, particularly anaerobic strains like Treponema denticola and various Prevotella species, these bacteria produce their own highly potent kinases.
Oh, wow, so they join the fight.
Yes. When the bacterial kinases synergize with the endogenous TPAs released by the traumatized alveolar bone, The fibrinolytic activity completely overwhelms the structural integrity of the clot.
And then the scab washes away.
Exactly. The fibrin mesh dissolves, the clot is mechanically lost, and you are left with exposed, raw bone.
Which totally explains the localized necrosis. I mean, the bone lining, the lamina dura, relies on the periodontal ligament for a significant portion of its vascular supply, right?
That's entirely correct.
So when you luxate and extract the tooth, you literally tear that ligament, rendering the superficial layer of the cortical bone essentially ischemic.
It loses its blood supply almost instantly.
And without the protective clot covering it, this ischemic bone is just subjected to the entire oral microbiome, saliva, and food debris.
And that superficial layer of bone becomes entirely devitalized. It dies.
Ouch.
Yeah, the exposed nerve endings within the Haversian canals and the marrow spaces are subjected to continuous chemical and mechanical irritation.
So that's why the pain is described as dull, radiating, and just agonizing.
Precisely. And the foul odor and halitosis the patient experiences, those are the direct byproducts of putrefaction.
Putrefaction? That sounds awful.
It is. The food debris packed into the empty socket is actively being fermented by the anaerobic flora, which produces these very strong volatile sulfur compounds.
Okay, so going back to our specific case, the Odell text notes the patient has trismus with only 22 millimeters of interincisal clearance.
Right, which is quite restricted.
Yeah, an ADC candidate might look at significant trismus and immediately assume a spreading fascial space infection, perhaps involving the masseteric or pterygomandibular spaces.
That's a very common trap.
But this case presents with moderate extral swelling and absolutely no systemic pyrexia. No fever.
Right, so trismus, in the context of a recent third molar extraction, requires a really careful differential analysis.
How so?
Well, in a true spreading space infection, you would expect significant fascial swelling, a rising temperature, and general systemic malaise. The patient would feel sick.
But our patient just has jaw pain.
Exactly. Here, the trismus is an inflammatory muscle spasm. It's trismus secondary to the surgical trauma itself.
Whoa, so it's from the actual procedure.
Yes. The repeated application of force, the retraction of the soft tissues, and the localized inflammatory exudate penetrating the adjacent medial pterygoid muscle, all of that leads to protective splinting.
Ah, the muscle is guarding the area.
Exactly. The trismus is a consequence of the difficult surgical procedure 4 days prior, not a direct symptom of the alveolar osteitis itself.
Let's isolate that 4-day window because timeline is the ultimate diagnostic discriminator in an ADC OSCE setting, isn't it?
It is arguably the most critical piece of data you have.
Right. Because if the pain started at day 0 and never let up, we are looking at severe surgical trauma.
Yes, exactly.
But if a candidate is presented with severe, unremitting jaw pain post-extraction, the differential must be rigorous. How do we biologically separate standard surgical trauma from alveolar osteitis?
It comes down to the biochemical timeline. Standard surgical trauma pain is mediated by the immediate release of prostaglandins and inflammatory cytokines secondary to tissue damage.
So it happens right away.
Yes, it peaks within the first 24 to 48 hours
Mm-hmm.
and follows a predictable downward trajectory as the acute inflammation subsides.
And it responds to normal painkillers.
Exactly. It is highly responsive to NSAIDs.
Right.
Alveolar osteitis, however, follows a distinctly different timeline.
Because of the clot dissolving.
Right. The initial clot forms, and the patient often reports the pain was totally manageable for the first 2 days.
But then day 3 hits.
The intense radiating pain only begins on day 3, 4, or 5. That delay represents the time required for the bacterial and endogenous fibrinolysis to fully dissolve the clot and for the superficial bone to actually become necrotic and inflamed.
Wow. Okay, what if the timeline is pushed out further and the pain is poorly localized? Odell mentions acute and chronic osteomyelitis in the differential.
That is a very different beast.
Yeah, I mean, in an age of prophylactic antibiotics, we rarely see true osteomyelitis of the jaws, but it remains a catastrophic complication.
It absolutely is. Osteomyelitis of the mandible is an infection of the medullary space itself.
So it's much deeper.
Yes. While alveolar osteitis is restricted to the superficial cortical lining of the socket, osteomyelitis involves the proliferation of a bacterial biofilm, often staphylococcal, deep within the cancellous bone marrow.
That sounds incredibly painful.
It is. The inflammation increases intramedullary pressure, which basically collapses the delicate blood vessels supplying the bone.
Leading to more ischemia.
Exactly. It leads to widespread ischemia and massive areas of bone death, which we call sequestra.
Differentiating that clinically without advanced imaging seems incredibly high stakes for a candidate.
It is, but it relies heavily on patient profiling and pain characteristics. Osteomyelitis pain is deep, boring, and crucially, it is poorly localized.
Because it's deep in the marrow.
Yes, because it involves the entire medullary cavity. The patient will struggle to pinpoint the exact socket, whereas a dry socket patient will point directly to the extraction site.
It hurts exactly here versus my whole jaw throbs.
Precisely. Furthermore, osteomyelitis almost exclusively presents in patients with severe underlying systemic compromises.
Like uncontrolled diabetes.
Yes, or severe immunosuppression or pre-existing conditions that sclerose the jawbone, like advanced Paget's disease. And importantly, acute osteomyelitis usually takes weeks to manifest clinically with suppurative drainage, not 4 days.
Okay, so the 4-day mark is our safety net for dry socket. Speaking of structural damage, though, a difficult extraction of a lower eighth often involves significant distal bone removal and aggressive elevation.
It certainly does.
We have to consider a fractured mandible. The anatomy of the mandibular angle, combined with the presence of an impacted third molar, creates a huge line of weakness.
That's true. Iatrogenic mandibular fracture is a rare but well-documented complication. However, the clinical presentation is entirely mechanical.
So it wouldn't present 4 days later?
Exactly. The pain is immediate, occurring the actual moment the bone yields.
And the occlusion would be off, right?
Absolutely. If you have a complete fracture, the pull of the masseter, medial pterygoid, and temporalis muscles will displace the proximal segment upward and forward.
And the muscles pulling down.
The myloid and anterior belly of the digastric will pull the distal segment downward and inward. The patient's occlusion will be grossly deranged immediately. It definitely does not present as a delayed onset pain 4 days later with an intact occlusion.
Okay, what about a retained root fragment? The lamina dura is already disrupted from the surgical attempt. If, say, the apical third of the mesial root snaps and is left in situ, could that trigger this cascade?
A retained root fragment alone is rarely the direct etiology of a delayed, agonizing pain syndrome like alveolar osteitis.
Really? But wouldn't it cause pain?
If a root fragment causes pain, it is almost entirely due to the extreme surgical trauma inflicted on the surrounding bone during the clinician's prolonged, failed attempts to retrieve it.
Ah, so it's the digging, not the root itself.
Exactly. When you inspect a classic dry socket, the base is an empty, echoing cavity of bare bone. Retained roots are practically never found inside a classic dry socket presentation.
That's a great clinical pearl.
And even if they were there, they would not be the primary driver of the fibrinolysis.
So the diagnosis really hinges on recognizing the delayed onset, the intensely localized pain, and the visual confirmation of an empty socket.
It's a clinical diagnosis through and through.
But the ADC exam heavily weights risk factor analysis. We need to anticipate this before the scalpel even touches the mucosa.
Prevention is always better than cure.
Odell highlights several specific risk factors. Anatomically, mandibular molars are vastly more susceptible than maxillary teeth. We know the mandible has a denser cortical plate and a less robust collateral blood supply compared to the highly vascularized maxilla.
The vascular density is absolutely the primary anatomical driver. A robust, rapid influx of blood is required to form a large, stable initial clot.
And the mandible just doesn't bleed as much.
Right. The dense, relatively avascular bone of the mandibular angle simply does not bleed as profusely as the maxilla.
But surgical technique is an equally massive variable, isn't it?
Oh, absolutely.
Sure.
Traumatic extractions where the clinician reflects a large mucoperiosteal flap, removes excessive buccal bone with a surgical burr, and spends 40 minutes luxating the tooth-caused exponential tissue damage.
So more trauma equals more dry socket risk.
Exactly. The greater the physical trauma to the bone and periosteum, the higher the release of endogenous tissue plasminogen activators. You are biologically priming the surgical site to destroy its own clot.
Looking at the patient's specific medical history from their Odell text, the data on smoking is universally understood, obviously.
Yes, smoking is a massive risk.
But what really caught my eye was the pharmacological overlap. Our patient is a young female taking an oral contraceptive pill.
Ah, the OCP.
My understanding is that exogenous estrogen profoundly shifts the hemostatic balance. We know estrogen upregulates clotting factors 2, 7, IX, and X in the liver, which actually increases thrombosis risk systemically.
That's correct.
But how does that lead to clot breakdown in the alveolar socket? Is the estrogen spike the primary culprit here?
The interaction between estrogen and hemostasis is really highly complex. While exogenous estrogen from oral contraceptives does increase systemic coagulation factors, it simultaneously upregulates the body's fibrinolytic pathways.
Wait, as a countermeasure.
Exactly, as a homeostatic countermeasure. It increases the baseline levels of plasminogen.
Oh, I see where this is going.
Right. Therefore, when the local surgical trauma triggers the release of TPA in the socket, there is an unusually high concentration of plasminogen available to be converted into plasmin.
So they have more of the clot-destroying enzyme ready to go.
Yes. The patient's systemic pharmacological state has essentially supercharged the clot-dissolving mechanism.
That is fascinating.
It is. This is exactly why epidemiological studies consistently show a significantly higher incidence of alveolar osteitis in females taking oral contraceptives compared to matched cohorts not on the medication.
That is a brilliant systemic interplay to keep in mind. But we also have to look at the pharmacology we administer locally.
The local anesthetics.
Yeah. The Odell text warns against excessive local anesthetic use. If we are using, say, an inferior alveolar nerve block with 2% lidocaine and 1.80 thousand epinephrine, the epinephrine acts as a potent alpha-1 agonist.
Which causes profound localized vasoconstriction.
Right. If we heavily infiltrate around the socket to achieve hemostasis during the surgery, are we essentially inducing localized ischemia? It's like crimping the hose right when you need to fill a bucket.
That's a great way to put it. Yes, you cause profound localized ischemia.
And if the vasoconstrictor stops the bleeding too well, the socket never fills with blood to form the initial clot.
Precisely. The vasoconstrictor prevents the socket from rapidly filling with a sufficient volume of blood immediately following the extraction. If the bleeding is slow and delayed, the resulting clot is often small, fragile, and loosely attached to the socket walls.
So it just falls out.
Pretty much. It lacks the structural volume to properly fill the defect and is very easily washed away or broken down.
So the clinical picture is complete. We have a female patient on oral contraceptives 4 days post-traumatic mandibular abstraction, presenting with localized pain and an empty socket.
The classic triad of signs.
Let's put ourselves in an OSCE exam scenario. The examiner asks, what imaging and serological investigations will you order to confirm your diagnosis?
The trick question.
Yeah, the defensive medicine instinct is to order a panoramic radiograph and perhaps a complete blood count just to be safe.
But the evidence-based answer, which is absolutely critical for demonstrating clinical competence to the ADC, is that no investigations are indicated.
None at all.
None. If the history, the delayed timeline, and the intraoral examination of the empty socket are entirely consistent with alveolar osteitis, prescribing a radiograph is an unnecessary exposure to ionizing radiation and an unnecessary cost.
Wait, in an OSCE setting, if we don't take a periapical radiograph, how do we legally defend missing a retained root tip or failing to identify the very early stages of osteomyelitis? Shouldn't we establish a postoperative baseline?
No, that's a common fear, but radiographs are indicated only when they have the potential to actually change your clinical management.
So when would that be?
If you suspect a retained root fragment because your surgical notes indicate the tooth was delivered incompletely, and you cannot visually or tactilely confirm the fragment in the socket, then a periapical radiograph is justified.
But if it came out whole?
If the tooth was delivered intact, a radiograph of a dry socket will merely demonstrate an empty socket outline. It gives you no new information.
And what about osteomyelitis?
Regarding early osteomyelitis, an X-ray taken at day 4 will appear completely normal. The significant demineralization required to produce that characteristic moth-eaten radiolucency takes a minimum of 2 to 3 weeks to become visible on a conventional radiograph.
Okay, that makes perfect sense. What about microbiological swabbing? Odell's text discusses anaerobic colonization. Shouldn't we culture the socket debris to target the specific bacterial kinases causing the fibrinolysis?
Again, no. Microbiological culture and sensitivity testing are strictly reserved for spreading systemic infections.
Because it's localized.
Exactly. Alveolar osteitis is fundamentally an inflammatory failure of local healing, not an acute spreading bacterial cellulitis.
So the swab won't tell us anything useful.
Right. Unless the patient presents with a systemic pyrexia, lymphadenopathy, or frank fluctuant pus draining from the fascial spaces, swabbing the socket will only confirm the presence of normal and opportunistic oral flora.
Which we already know is there.
Yes, and knowing exactly which bug is there does not alter our management protocol one bit.
Okay, this transitions us perfectly into management and the ADC communication task. We have a patient in agonizing pain who has been awake all night.
They're terrified.
They really are. They likely believe we shattered their jaw or left half the tooth behind. Reassurance is the absolute first step.
It is therapy in itself.
Right. The communication task protocol suggests framing it clearly, something like, a condition we call dry socket, which is experienced by pain, foul smell, and inflamed gums around the socket, usually happening 3 to 5 days after tooth removal. Although more common in bottom-back teeth, we will simply redress the tooth and prescribe you some stronger painkillers.
That specific phrasing is strategically designed for the patient's psychological state. It uses non-threatening terminology, and it validates their severe pain as a recognized, established condition rather than a surgical error.
That's so important for trust.
It is, and it immediately provides a tangible, simple pathway to relief. Lowering the patient's anxiety and sympathetic nervous system tone is a really critical adjunct to the physical therapy.
So for the physical therapy, Odell suggests gently irrigating the socket with warm saline. But in practice, I see many clinicians immediately reach for very 0.12% chlorhexidine to aggressively flush the socket.
Yes, that is very common.
Is there actual histological evidence that chlorhexidine improves the granulation rate? Or are we just treating our own anxiety about the bacterial load by reaching for the strongest antiseptic?
That is a highly debated distinction in clinical practice, honestly. Chlorhexidine possesses substantivity, meaning it binds to hydroxyapatite and mucosal surfaces, providing a prolonged bacteriostatic effect.
Which sounds good on paper.
It does. However, multiple in vitro studies demonstrate that chlorhexidine is highly cytotoxic to human fibroblasts and osteoblasts.
Oh, so it kills the healing cells.
Yes. If you aggressively irrigate raw, exposed bone with a high concentration of chlorhexidine, you risk chemically damaging the very fibroblasts that are attempting to migrate from the socket walls to form the new granulation tissue.
Wow, so we are shooting ourselves in the foot.
In a way, yes. Warm, sterile saline provides excellent mechanical debridement. It flushes out the necrotic debris, food particles, and local bacterial load without the inherent cytotoxicity of an antimicrobial agent.
Mechanical cleansing over chemical sterilization.
Exactly. The goal of irrigation is mechanical cleansing, not total sterilization of an environment that is constantly, bathed in saliva anyway.
That makes a lot of sense. Once the socket is flushed, we move to the dressing. Proprietary dressings like Alveogyl are the gold standard. Everyone uses it, but what is actually doing heavy lifting pharmacologically? It's not just a physical plug, right?
No, it's not. The efficacy of a dressing like Alveogyl lies in its multi-agent composition. It typically contains eugenol, which provides a profound, immediate analgesic effect.
By numbing the bone.
By suppressing nerve conduction in the exposed nerve endings of the Haversian canals, yes. It also contains betambin, a localized topical anesthetic, and iodoform, which provides a sustained, mild antimicrobial action without being highly cytotoxic.
And the physical matrix itself.
The fibrous matrix of the dressing, which is often compounded with a resorbable carrier like Pengho or Jambi fibers, acts as a physical barrier to prevent further food impaction while the pharmacology soothes the bone.
Okay, but Odell highlights a specific mechanical trap here. If a little dressing is good, the instinct is to pack the socket completely full to the gingival margin to maximize the analgesic effect and seal the bone.
A very natural but incorrect instinct.
The text explicitly advises against this. But if the socket is a void, why wouldn't we want to pack it completely to protect the bone entirely? Are we just relying on the minimal dressing to act as a physical roof while the floor heals?
Basically, yes. Healing of an extraction socket occurs via secondary intention. Granulation tissue must proliferate from the highly vascularized base and lateral walls of the socket, migrating upwards to eventually epithelialize at the crest.
Right.
If you forcefully pack the entire socket volume with a slowly resorbing or non-resorbable paste, you create a dense physical barricade.
Like pouring concrete in a tunnel.
Exactly. The fibroblasts and endothelial cells physically cannot advance through the dense iodoform matrix. You essentially arrest the healing process.
So what's the correct technique?
The correct technique is to place a minimal amount of dressing loosely into the coronal third of the socket, just enough to cover the most exposed coronal bone and block the orifice from food impaction. You leave the apical 2/3 empty to allow the biological proliferation of granulation tissue.
Okay, and the systemic pharmacology. We have flushed the socket, placed the dressing, and we need to manage the patient's pain.
Right, pain management is key.
The pain is driven by intense localized inflammation, so NSAIDs like ibuprofen are the logical first-line choice, assuming no medical contraindications like peptic ulcer disease or severe asthma.
Yes, NSAIDs are perfect for this.
But the most critical pharmacological point, the one that will fail a candidate instantly if violated, is the prescription of systemic antibiotics. The patient has exposed necrotic bone colonized by bacteria. The halitosis is overwhelming. The instinct to write a script for amoxicillin or metronidazole is immense.
Oh, it really is.
Yeah.
But you absolutely have to resist that instinct entirely.
Mhm.
Prescribing systemic antibiotics for alveolar osteitis is fundamentally flawed on a biological level
Because it's localized.
because of the blood supply.
Yeah.
Systemic antibiotics rely on the circulatory system to deliver the active drug molecules to the target tissue.
And the bone is dead.
Exactly. As we established, the superficial bone of a dry socket is completely avascular and necrotic.
Right.
Blood is not flowing through that superficial layer.
So the drug never gets there.
Right. Therefore, the systemic amoxicillin physically cannot reach the anaerobic bacteria colonizing the surface of the bone.
You're just giving them side effects for no reason.
Precisely. You are subjecting the patient to the risks of antibiotic therapy, gastrointestinal disruption, potential anaphylaxis, and contributing to global antimicrobial resistance while providing absolutely zero therapeutic concentration of the drug to the actual site of the pathology.
It's an inflammatory healing failure, so local problems require local, non-systemic solutions.
Perfectly said.
Okay, we've established that localized mandibular pain at day 4 is our classic alveolar osteitis. But if we change the geography to the maxilla, the biological math shifts completely.
Yes, it becomes an entirely different problem.
A maxillary first molar socket that fails to heal isn't just a bone issue, it's a boundary issue.
Yeah.
Let's examine case 18 from Odell's text. A patient presents 2 weeks post-op from an upper left first molar extraction.
Okay, so a much longer timeline.
Right. They have a dull, throbbing pain, nasal discharge, and a very specific, alarming complaint. Fluid escapes into their nose when they drink.
Oh boy, that specific symptom profile is pathognomonic for an oroantral communication that has matured into a fully epithelialized oroantral fistula, or OAF.
Explain the anatomy there.
Well, the apices of the maxillary posterior teeth, particularly the first and second molars, often sit in intimate proximity to the floor of the maxillary sinus.
Sometimes they even poke through, right?
Yes, in many cases, the roots protrude directly into the sinus cavity, separated only by the very delicate Schneiderian membrane. When the tooth is extracted, especially if the roots are divergent or hypersmentosed, the thin bony floor and the membrane are torn,
Creating a hole.
creating a direct conduit between the septic oral cavity and the sterile maxillary sinus.
And the diagnosis at this 2-week mark isn't just that there is an anatomical hole. The hole itself isn't generating the dull, throbbing pain, is it? The diagnosis is acute maxillary sinusitis secondary to the oroantral fistula.
Precisely. Think about the mechanics. Every time the patient swallows, the negative intraoral pressure pumps oral bacteria, saliva, and food debris directly up through the fistula and into the sinus cavity.
That's horrifying.
It causes massive inflammation. The ciliated pseudostratified columnar epithelium of the sinus, the Schneiderian membrane, becomes violently inflamed.
And it can't drain.
No, because the ostium, the natural drainage port of the sinus into the middle meatus of the nose, swells shut due to the edema. The sinus becomes a sealed, infected chamber filled with purulent exudate.
Which causes the intense throbbing pain.
Exactly. And referred pain to the adjacent maxillary teeth.
Wow. Unlike the dry socket where we strictly avoid imaging, investigating an OAF demands radiographs, doesn't it?
Absolutely. Imaging is mandatory here.
A periapical film of the socket might show a break in the sinus floor, but the intact buccal and palatal cortical plates often obscure the defect. Odell recommends an occipital view, also known as a Waters view, or a panoramic tomograph. What exactly are we looking for on that imaging to confirm the secondary sinusitis?
You are evaluating the radiolucency of the sinus cavities bilaterally to detect asymmetry. A healthy air-filled maxillary sinus appears radiolucent, or dark, on a radiograph.
But the infected one?
A sinus infected via an OAF will appear radiopaque or cloudy. You might see a distinct fluid level, mucosal thickening along the sinus walls, or complete opacification of the cavity due to the accumulation of purulent exudate.
We're also checking for root tips,
Yeah.
right?
Additionally, the imaging is crucial to rule out the presence of a fractured palatal or mesiobuccal root tip that may have been displaced upwards into the sinus cavity during the extraction attempt.
So management of an OAF is drastically different from a dry socket. We cannot just pack the defect with Alveogyl, because pushing dress material into the sinus will only exacerbate the foreign body reaction and the sinusitis.
That would be a disaster. We need a multidisciplinary pharmacological and surgical approach.
Start with the pharmacology.
The immediate goal is to treat the acute sinusitis. Unlike the avascular dry socket, the inflamed sinus membrane is highly vascularized, so systemic antibiotics are absolutely indicated here.
What kind?
Because the infection is driven by a mix of oral flora and respiratory pathogens, a broad-spectrum antibiotic, often amoxicillin with clavulanic acid to counter beta-lactamase-producing strains, is standard.
What about the congestion?
You must also prescribe systemic or topical nasal decongestants, like ephedrine nasal drops. That reduces the swelling around the ostium and allows the sinus to drain naturally into the nasal cavity.
Okay, so clear the infection first. And once the acute infection is controlled, the anatomical defect must be closed. A mature fistula will not close by secondary intention, will it?
No, because the epithelial lining of the oral mucosa migrates down into the socket and joins with the epithelial lining of the sinus.
So it heals open.
Yes, it creates a permanent continuous tract.
Oh.
Surgical closure is mandatory.
How is that usually done?
The most common technique is the buccal advancement flap, originally described by Raman. The clinician raises a broad trapezoidal mucoperiosteal flap on the buccal aspect of the socket.
And then just stretches it over.
Not quite. The periosteum at the base of the flap has to be horizontally scored or incised. This releases the inelastic periosteum, allowing the elastic mucosal tissue to be stretched and advanced over the socket. Then it completely covers the bony defect and is sutured securely to the palatal tissue under zero tension.
Zero tension is key. The post-operative instructions for a buccal advancement flap are incredibly strict. You have stretched mucosal tissue over a void, relying on delicate sutures to hold it against the forces of mastication, speech, and respiration.
It's very fragile at first.
Odell emphasizes advising the patient against nose blowing, sneezing with their mouth closed, or using a straw.
Because of the pressure.
Right. These actions create massive pressure differentials, either positive pressure pushing down from the sinus or negative pressure pulling from the mouth, that will instantly rip the sutures and destroy the flap repair.
The physical mechanics of the repair are highly vulnerable during the first 72 hours. Even aggressive mouth rinsing can disrupt the delicate fibrin seal forming at the flap margins.
So no rinsing at all.
The protocol often advises absolutely no rinsing for the first 24 hours, followed by exceedingly gentle bathing of the area with chlorhexidine to maintain hygiene without mechanical disruption.
Makes sense. Let's shift our clinical focus from the maxilla back to the mandible, push the timeline out to 3 weeks, and introduce a highly concerning neurological symptom. Case 16 from Odell's text.
Okay, this is a heavy one.
Yeah. The patient is 3 weeks post-extraction. The socket is completely devoid of epithelialization. Instead of normal organized healing, there's a mass of frustrated, irregular granulation tissue proliferating from the socket. Crucially, the patient reports paresthesia numbness and tingling of their ipsilateral lower lip.
A presentation combining delayed, irregular tissue proliferation with unprovoked neurological deficits should trigger immediate, massive clinical alarm bells.
Because it's not an infection anymore.
Right. A 3-week timeline for a non-healing socket is already highly suspicious for underlying pathology. But the paresthesia of the lower lip indicates that the inferior alveolar nerve, which runs right through the mandibular canal, is being actively compressed, invaded, or destroyed.
And a dry socket wouldn't do that.
A localized inflammatory process like a dry socket does not spontaneously compress a major nerve trunk 3 weeks after the extraction.
So the biological math points away from an inflammatory healing failure and strongly toward a neoplastic process.
Malignancy, yes.
We are looking at a potential malignancy within the body of the mandible. The tumor cells are simultaneously proliferating into the socket space, preventing normal epithelialization and presenting as that abnormal, easily bleeding mass, while simultaneously expanding within the medullae bone to compress the inferior alveolar nerve.
Exactly. Squamous cell carcinoma, either originating from the overlying mucosa and invading the socket, or potentially a primary intraosseous carcinoma or metastatic deposit from a distant primary tumor, must be at the very top of your differential diagnosis.
So that frustrated tissue is actually tumor tissue.
Yes. The frustrated granulation tissue is often a mass of dysplastic cells exhibiting unchecked angiogenesis, which is why it bleeds so profusely upon gentle probing.
The clinical action here is aggressive and rapid. We are not irrigating this with saline and placing a dressing. Odell suggests immediately performing vitality tests on the adjacent teeth.
Yes, to rule out a massive chronic periapical granuloma or cyst that might be causing an inflammatory mass and some expansive pressure, though this is less likely to cause sudden paresthesia.
Vitality testing is a necessary baseline, but the primary investigative actions are radiological and histological, right?
Absolutely. An urgent panoramic radiograph is required to evaluate the bony architecture.
What are we looking for on the OPG?
You are looking for destructive, poorly defined, ragged radiolucencies indicative of invasive destructive bone pathology. It's often described as having a moth-eaten or permeative pattern.
But the X-ray doesn't give the final diagnosis.
No, however, a radiograph only shows the destruction that has already occurred. It does not provide a definitive diagnosis. The absolute mandate is an immediate referral for an urgent incisional biopsy of the abnormal tissue mass.
You cannot delay this.
You must suspect and rule out oral cancer before entertaining any other diagnosis.
It is a stark reminder that a simple tooth socket is effectively a deep window into the systemic health of the medullary bone.
It really is.
And speaking of systemic health, the final scenario we must dissect is perhaps the most insidious, as it is entirely iatrogenic. Case 23 from the Odell text deals with bisphosphonate-related osteonecrosis of the jaw, or MRONJ, now more broadly categorized under medication-related osteonecrosis of the jaw, MRONJ.
Right, MRONJ.
The clinical presentation is alarming in its lack of acute symptoms. An older patient presents stating their tooth just fell out. Upon examination, there's a large void of exposed, yellow-gray, necrotic bone. There's no active bleeding, no granulation tissue, and astonishingly, the patient is entirely pain-free. Reviewing their medical history reveals long-term use of alendronate for osteoporosis.
This is a complex pharmacological complication that every practicing clinician must understand deeply.
How do bisphosphonates actually work on the bone?
Bisphosphonates, particularly the nitrogen-containing varieties like alendronate or intravenous zoledronate, are profoundly potent drugs utilized to manage osteoporosis, Paget's disease, or hypercalcemia of malignancy.
And their target is the osteoclast.
Yes. Their primary mechanism of action is the severe inhibition of osteoclast function. They bind to the hydroxyapatite crystals in the bone matrix.
Okay.
When an osteoclast attempts to resorb that bone, it ingests the bisphosphonate. The drug then interferes with the mevalonate pathway, specifically inhibiting farnesyl pyrophosphate synthase.
That's a mouthful. What does it actually do to the cell?
This leads to the disruption of the osteoclast's rufford border, the loss of its resorptive capacity, and ultimately early apoptosis of the cell. It kills the cell.
The pathophysiology here is critical because we often think of bone loss as the enemy. We want to stop osteoclasts from breaking down bone in osteoporotic patients. But bone is not a static block of concrete, right?
Far from it. It is a highly dynamic, living tissue that requires constant microscopic remodeling to maintain its structural integrity.
So osteoclasts are actually necessary.
Osteoclasts are absolutely required to clear away old microdamaged bone so that osteoblasts can lay down fresh, highly vascularized osteoid.
Okay, so when you arrest the osteoclast function for years using bisphosphonates, you arrest the entire remodeling cycle. The bone becomes extremely dense and heavily mineralized, which prevents osteoporotic fractures, but it also becomes brittle.
Yes. Furthermore, bisphosphonates, particularly the intravenous forms, have powerful anti-angiogenic properties.
Meaning they stop blood vessel formation.
Exactly. They inhibit the formation of new blood capillaries. Over time, the medullary space of the jawbone becomes profoundly ischemic. The bone literally dies from the inside out due to a lack of blood supply, creating a state of avascular necrosis.
This changes our entire perspective on the dental extraction in these patients. The extraction didn't cause the bone to die.
No, not at all.
The bone was already dead long before the patient sat in the dental chair. The tissue was necrotic, but entirely asymptomatic because dead bone does not have a functioning nerve supply to transmit pain.
Nor a blood supply to mount a painful inflammatory response.
So the extraction merely unmasked the necrosis by breaking the thin mucosal barrier, exposing the dead bone to the oral environment.
That is exactly why the tooth just fell out. The periodontal ligament had necrotized, and the supporting bone was completely avascular.
So the management of MRONJ is fundamentally different from any other condition we have discussed, largely because surgical intervention is highly contraindicated in early stages.
Yes, surgery will usually make it worse.
And we encounter the antibiotic myth once again here, right? Systemic antibiotics do not penetrate dead bone because there are no patent blood vessels to carry the drug into the necrotic matrix.
Exactly. The exposed bone itself is initially sterile dead tissue, though it will eventually become colonized by superficial oral bacteria.
So if we cannot rely on antibiotics, and we cannot surgically excise the bone without risking further necrosis of the adjacent ischemic bone margins, what is the protocol? Odell emphasizes a largely palliative approach.
The primary goal in stage 0 or stage 1 MRONJ, where there is exposed bone but no frank infection or pain, is to prevent secondary infection of the adjacent viable soft tissues.
How do we do?
This is achieved through rigorous, meticulous oral hygiene and the prolonged use of topical antimicrobial mouthwashes, like 0.12% chlorhexidine. You monitor the exposed bone carefully.
And just wait.
Often, over many months or even years, the necrotic segment will slowly demarcate and separate from the underlying basal bone, forming a sequestrum that can then be gently lifted away without surgical trauma.
So patience is the key.
Yes, heroic surgical resections with wide margins are reserved only for advanced stage 3 cases involving pathological fractures or extraoral fistulas, and even then, the outcomes are highly unpredictable.
The Odell text touches on the concept of prevention and the controversial drug holiday. If we identify a patient on oral bisphosphonates who desperately needs an extraction, is there clinical value in having their physician halt the medication for 3 to 6 months prior to the surgery?
The theory is that removing the drug allows some localized recovery of osteoclast function and angiogenesis to support post-extraction healing.
But does it actually work?
The efficacy of the drug holiday is a subject of intense debate and evolving guidelines. The primary issue is the pharmacokinetics of bisphosphonates. These drugs have an incredibly high affinity for bone hydroxyapatite,
They stick to the bone.
like glue. Their half-life within the skeletal matrix is not measured in hours or days, but in years, often upwards of 10 years.
10 years, wow.
Therefore, halting an oral bisphosphonate for 3 months may slightly reduce the level of freely circulating drug, but it does very little to clear the massive reservoir of the drug already embedded in the jawbone.
So it's arguably pointless.
Current guidelines generally emphasize that the duration of bisphosphonate therapy, specifically whether the patient has been taking the drug for more or less than 4 years, and the route of administration, oral versus intravenous, are much stronger predictors of risk than a short-term drug holiday.
Which brings us to the most crucial non-clinical aspect of MRNJ, the medico-legal liability. A dentist who extracts a tooth in a bisphosphonate patient without proper protocol is stepping into a massive legal minefield.
Informed consent is the absolute bedrock of managing these patients. The patient must be explicitly and thoroughly warned prior to any surgical intervention that due to their specific pharmacological history, their jawbone has a significantly compromised healing capacity.
They need to know the worst-case scenario.
They must understand that the socket may permanently fail to heal, that they may develop exposed necrotic bone, and that there is no guaranteed surgical cure for this complication. Detailed, contemporaneous record-keeping documenting this specific conversation is your only defense against a claim of negligence if MRNJ does develop.
We have covered an immense amount of clinical ground today. For ADC candidates and practicing clinicians alike, the absolute necessity is the ability to rigorously distinguish between vastly different failures of healing based almost entirely on precise timelines, anatomical locations, pharmacological history, and highly specific pain characteristics.
It really is a diagnostic puzzle.
We have dissected the localized inflammatory fibrinolytic failure of a dry socket, peaking precisely at 3 to 5 days with intensely localized boring pain. We have analyzed the anatomical boundary breach of the oroantral fistula in the maxilla, presenting weeks later with fluid entering the nasal cavity.
And the malignancy cases.
Yes, we explored the sinister, destructive pathology of an oral malignancy presenting as a non-healing socket coupled with sudden nerve compression. And finally, we unpacked the systemic, drug-induced avascularity of MRONJ presenting as painless, exposed necrotic bone.
Each of these scenarios perfectly demonstrates why rote memorization is insufficient for advanced clinical practice. You cannot simply look at a void in the alveolar ridge and assume it is alveolar osteitis.
You have to dig deeper.
You have to interrogate the biological history, understand the pharmacology, and apply a rigorous differential diagnostic framework.
The risk factors we discussed today, mandibular bone density, the extent of surgical trauma, the precise mechanism of oral contraceptives, the half-life of bisphosphonates, all rely on our current ability to manually synthesize a patient's medical history. But the landscape of diagnostics is shifting rapidly.
That is precisely where the future of this field lies. With the rapid integration of artificial intelligence in analyzing CBCT scans for subtle variations in trabecular bone density, combined with algorithmic evaluations of vast, complex systemic medical histories and pharmacological interactions, we are approaching a paradigm shift.
AI predicting necrosis.
Exactly. Will we soon be able to algorithmically predict with high statistical certainty exactly which patients will experience catastrophic fibrinolysis or develop a vascular osteonecrosis before we ever pick up a surgical instrument?
That would change everything.
Could an AI-driven risk score generated on our clinical monitors fundamentally alter our surgical approach, pushing us toward alternative non-extraction therapies in high-risk patients? It is a profound, provocative thought for the future of preventative surgical planning.
For more dental examination prep tips and clinical deep dives, please subscribe our Spotify and YouTube channel and share this episode.